And for my third and fourth year in college, I pretty much made most of my degree was mostly done, so I had extra time. So I pretty much worked full time my third and fourth year. And of course, enjoying life being a college kid. And then from there, that's where I met my first PA.
Hi, everyone. Welcome to eShadowing. Let's get started. With this new system, I basically have to add our guest, Thao Allen. So excited to have her. I gotta get her participants. Okay, here we go. Keeps moving up. Okay, here we go. Hi, Thao, welcome.
Thank you for having me.
Thank you so much. I'm so sorry again about the confusion last week.
Oh, it's okay, I understand, technical difficulties, IT challenges, it all always happens.
Thank you. So everyone, we have Thao Allen. Thao is a spine specialist PA, and we're so excited to have her on eShadowing tonight. Welcome, Thao.
Thank you.
Right, so we're gonna jump right into it. Of course, we always get started with wanting to learn more about your journey, your why behind your becoming a PA, and how you kind of got started, your pre-PA journey, what you majored in, what your patient care hours look like, and the PA school that you went to. So can you tell us more about how you got started in PA and why PA?
Oh, sure. So let's see. Many, many moons ago, back in, I started at VCU, which is in Richmond, Virginia, where I went to college, and I started as a biology major in pre-med track, starting in 2003. And, being a first-generation American, coming from an immigrant family, of course, they're like, we worked hard, you need to be a doctor. And so all I knew was like, okay, well, let me see if I like medicine. And because, with VCU, we have access to the medical school and the medical campus at MCV. There's a huge hospital system. I then was volunteering and getting my hours in, and just pretty much it was just sitting with patients for the most part, transferring documents, physical documents, because back then there were paper charts, and physically bring them, or organizing notebooks, because this is before EMR was truly established yet. A lot of it was still paper, and everything was scanned in. So in college, I got in my hours, and then decided I think I like medicine, and so I had the opportunity to then get more experience being a medical scribe in an emergency room. And for my third and fourth year in college, I pretty much made most of my degree was mostly done, so I had extra time. So I pretty much worked full time my third and fourth year. And of course, enjoying life being a college kid. And then from there, that's where I met my first PA. And it was a group of PAs that worked pretty much in the emergency room department, doing more the lower acuity patients, lacerations, cold, kind of like what you see like urgent care patients. And so from there, I got to know them, but also at the same time, also getting to know the ER physicians. And at that point, I was pretty much writing the HPI or typing in the HPI. Everyone had a subset. So if there was like, an acute MI, I would call the on-call cardiologist. It was a STEMI. I put in all the orders because there was a template. So pretty much like I got my reps in, like figuring out like the algorithm for most of these like acute syndromes. And so from there, I'm like, okay, this is not too bad. Being a science nerd, like this is all like straightforward. But I think what really made me switch over thinking like, okay, I want to go to med school and be a doctor versus I wanted to be a PA was like, I wanted a shorter educational program because I at my time, I think in my mindset, I was like, I don't know if I have the patience to dedicate that much time. And, being young and they're like, oh yeah, the PA track, that's the way to go. It's definitely shorter. I'm like, okay, sure. That sounds great. But, I definitely wanted a balance of having a good time because I was still in the mindset. I wanted to enjoy myself. Education, came naturally to me. And I'm like, okay, whatever. I just wanted to hit the ground running and start working. And so that's kind of what helped me decide, like, okay, I'm going to go for the PA track. But I think a key thing that definitely that is important, I think, for most people on their journey and figuring out their future is mentorship. And I think along your way in your life and finding people, on their path and have chosen, their destination or what their career is, ask questions, figure out, why are they doing this? What is their life like? Does it give them joy? Does it make them happy? And I think I've been very blessed having great mentorship along the way from, my first job being a waitress and figuring out, navigating that scene, becoming an adult and building self-confidence to getting myself into medicine and really enjoy, interacting with people, all day long. So from there, back then prerequisites or the hours, like the patient care hours wasn't mandatory for a lot of the programs I was in, for that I applied to. So even though I had over 1,000 hours of patient contact type of care, I applied to Shenandoah University, which is in the Shenandoah Valley in Virginia. That was a program at the time that did not require hours, but I got accepted early admission through Shenandoah and Drexel in Philadelphia, and then I just picked one. Kind of like end of the summer, early fall. I'm like, okay, I didn't want to pay to hold a seat to keep going and applying. I got into a school, and it worked out great. And I chose Shenandoah over Drexel just because I wanted to be in somewhere more low key. It definitely is a smaller town versus like the city. And because I'm focusing on school, I didn't want the city to be a distraction. And also, being in the city is very expensive. And so I chose that route. Did the program, met my husband. So my husband and I are both PAs, and he commissioned into the Air Force. So he was an Air Force PA while in school to pay for about 60% of his tuition. His commitment was 3 years. And being the smart girl that I was, I did not follow him because I didn't have a ring on my finger. I stayed in Northern Virginia, which is where I'm from. And he went to Arkansas. He was stationed in Little Rock, Arkansas. And then we were committed to each other. And then we got engaged. And then he joined me in Northern Virginia. And so I work for a spine practice, and he works for an outpatient cardiology practice.
Oh, nice. And
yeah.
Have you always been in spine?
I have, yeah. So back in 2000, end of 2009, early 2010. So about December 2009 was when I graduated, and I just started applying toward the end of my toward the end near graduation. I just started looking because I knew, I wanted a short window. I wanted to get working. And so I started applying everywhere, and online there was this, it was just marketing. It looks like a spine practice looking for a PA, potentially surgical, potentially not. It was very, very broad. And at the time, I wasn't really necessarily interested, but I was like, this is good practice for me. I'm not a person that necessarily made a decision to decide what I wanted to do, but I felt like I don't know enough. So I'm going to learn by applying and interviewing and see what they have to say. And so I was very open-minded. And so it was my first in-person job interview. So this was January of 2010. And they kind of blew me out of the water because I wasn't expecting to like it. I trained myself. I knew what to say. I was really hungry. And, I wanted to work hard and show them integrity. And I knew I would get it. I was just like, I got it. And so, all they're looking for is confidence, because as a new graduate, that's all you can show and offer, because that's all you have. You don't know anything coming out of school. You know enough, right? And so a week later, they offered me the position, and I was like, oh, wow, I think this is it. I just, through a gut decision, I went forward with it. And next thing you know, I'm get thrown into this position, not knowing anything about spine, as you know, most programs are primary care based. They have their own fellowship program if you make it through. And so it was a rigorous fellowship program. So I'm a fellowship trained spinal PA, but it's 1 year of internship and 1 year of residency. And I've been doing this ever since. And so I've been a spine PA for over 12 and a half years. I am also a surgical PA. I operate with a surgeon. We have a group of surgeons. So we're a unique practice. Our practice is located in Reston, Virginia, which is in Northern Virginia, right side of Washington, D.C. We're a concierge type practice, and we are multidisciplinary practice. So that means that we have our own physical therapy facility. We have our own non-operative arm, which includes, we have a regenerative center, which I can always talk about. It's really neat, using your own body to heal. We have a non-operative practice, which is more like, and we have through that we have a fluoroscopy suite, procedural suite, where these guys do different types of procedures, injections, ablations. And so, again, I think in treating spinal care, most patients don't want to go to a surgeon because they don't want surgery, but that's why it's really important. You want to go to a spine specialist because, they want to know what's on the menu. They want to know what it is, what they can what they can avoid, and to be informed and to empower them with knowledge. And that's how we set the environment for them. And obviously I love my job because I've been there for so long. But yeah, so I'm a PA, which means I operate with a surgeon or operate with our group. We have total of 4 surgeons currently, and I'm assigned to one, but I can work with any of them. We do anything from the typical surgeries, which is like microdiscectomies, degenerative discs, type of back pain, stenosis, deformity, scoliosis, and the big stuff. And so we do big deformity as well. And so from adolescent to adult. So we do everything. So that it's been really fun. I also, because I've been there for quite a while, I'm also the lead PA. I manage a team of 10 of us on the operative side. It's so cool to work with other PAs and to have a team. Autonomy is relative. It's interesting how you view autonomy. My husband, for example, works for outpatient cardiology. He has his own schedule, his own panel of patients. And while he does communicate with the cardiologist, when appropriate, when needed, but pretty much he runs his own ship. For me, because I do work, with a spine surgeon, these patients need to see their spine surgeon, to develop that relationship. So, but in a sense, if you put in the time how our model is built, we truly have autonomy. By the time I'm done seeing the patient, I've reviewed their x-rays, their MRI or CT scans, where their symptoms are coming from, to understand the nature of their pathology, what the non-operative, operative options are, and what is the probability or the success of what the treatment options. And then we formulate a plan together and getting to know them, where are they in life, how much symptoms are disrupting their quality of life. And from there we reach a conclusion. So we build the rapport, and that's really important for the PA role. And then I'll present to the surgeon, and then the surgeon comes in, and we really, and the surgeon will then, off of, again, our strong relationship, will then just reiterate everything that, I've just said. And it just sounds so good to re-inform, the patient, because it's a lot of information that we're all on the same page. And so from the patient's perspective, it's very cohesive. It's a very team cooperative type of effort. And that's why, we have a great relationship with our patients, because, who wants spine surgery and who wants to invest in that? And obviously it's very fearful for them to think about these kind of things and make these kind of decisions, and we help them through the process. And so, yep, I do a little bit of everything. So.
Wow. So, great story. So thank you so much for sharing that with us. I have so many questions already, but one thing that a student wanted to know is about how that transition was like, being a new grad and going into, such a specialized field? And did doing the fellowship help you, or how much did it help you in the learning?
I think a lot of people ask, like, okay, there are postgraduate programs out there that offer like an extra focus on surgery, and is that worthwhile or not? I get that question a lot, and I think a lot of these programs, the structure is very challenging, because usually if there are programs that offer that, it's usually they need an extra body or a soul to jump into, to be able to round inpatient, do the inpatient care if needed, and really priority with these types of institutions. The med students, the residents, the interns are going to have first dibs in really doing the first assist. And so, I can't speak from personal experience, but from, colleagues and friends who have gone through a program like this, it usually is not what they expect, and more time away before they actually start working, because you have typically, they pay you much less than average for you, because they're, giving you a special program. And so, again, I did this like over a decade ago. And so, the old school type of surgeons that come in, it's very militant. It can be very hard. I personally am not an outward stressor. I'm like, okay, I want to work hard. I can get any task. Anything I do is wrong. How do I fix it? How do I do better? And through that dedication, I had alopecia because of my stress. It was one of those things that, like, oh my God, like, what is this? And I'm like, and I'm like, oh, I must be from stress. I don't feel it. I'm like, I'm just working hard. But definitely this field of this, of this type of medicine, it can definitely, people will say, it churns through, it's a lot of high turnover. It definitely takes a certain type of individual that enjoys this type of work, because it is not a controlled, repetitive setting. And so to do inpatient medicine or emergency cases, and something comes on and you have to pull an audible or get teams to come together. You have someone really sick, and now you got to get cardiac clearance or medical clearance. You got to figure out, this person needs surgery ASAP. You got to, contact the anesthesia team. So there's a lot of like things that are going on. And so in that aspect, if you want to consider a field like this, you really have to enjoy the kind of fast-paced environment. And when you interview at these kind of places, these are the things that you want to consider, the transparency. Because I also, I onboard all of our PA, a lot of our PA team when they join us, and also part of the interview process when we do hire, we're very transparent in the type of quality of life and the type of environment that they that our team is, and how we work and how we function, and the expectation. But going back to the question originally, that transition of going from school, because I think it was about 4 weeks or 3 weeks or so, about a month or so from graduation to when I started. I took my exam on my pants in early January, and then I found out that I passed right before I started, I believe, something like that. And so I didn't have much time. And so, then you get jumped into it. And a part of that too is like, I was very lucky because you have to have somewhat of an onboarding process with any of these new grad into specialty roles. You have to ask, like, what's the onboarding like? Do they focus on education in the foundation and training? Because they want to utilize you for your autonomy, for your brain, and to have collaborative thinking. And so I was very lucky in that regard, because there was a lot of emotion, there was a lot of intensity, because they invested in me and it has to work. And so I had a lot of long nights in the beginning, being that I was, single, no kids. I had a lot of late nights of just studying anatomy, foundation of spine, the complexity of the neuroanatomy, then plans and options and the biology behind it, and then the next step, what came along naturally that I didn't know I had to really think about is like, how to connect with patients, how to deal with chronic pain patients, how to deal with emotion, how to deal with people that are challenging. And that's just something you can't prepare for, but also you have to figure out how to make it work, because these people, you have to figure out how to work with these patients. But for the most part, the majority is like you interact and deal with wonderful people that are just will admit to you and bare their soul. They're just in pain. They want to be a good spouse, a good parent. They want to work. They want to function, and it's hard to do that. And so, but if that answers, I think, part of the original question, this is a lot, but yeah, it was a lot. And again, a part more comes down to it is asking like the how and why, like, is this something that you enjoy and you would think you'd like? Yeah. But pretty much that first 2 years, because, we have fellowship trained spine surgeons, not only are they have an orthopedic residency, then they go to extra training and have a fellowship in spine and doing spinal surgery. And that's what makes them exceptional, because, you don't have to have one, but in order to be really good and to be respected in the community, it is always ideal to have a fellowship. And back then, there were not as many programs, but now it's kind of like common sense. And I think it's more natural. If you want to do spine, I think most of the younger or newer surgeons in practice, they all get a spine fellowship in order to start.
Thank you so much for that.
Mm-hmm.
So we're going to backtrack a little bit. We had a student ask, when you were interviewing, did you say anything about the shorter education time for wanting to be a PA, or is that influencing you? Do you remember?
I'll be as honest with you guys as I possibly can remember, but I think at the time, I don't think necessarily worded it that way. But of course, the common question was like, Thao, why didn't you go to medical school? Why did you become a PA? And I think that one of the most common things that, of course, which is obviously true. I definitely, I wanted that work-life balance. I knew I was in a serious relationship, and more likely, I wanted to have children and to figure out how to find that balance in life. And my dedication is, I've always been a hard worker, but I didn't want to necessarily, I wanted to figure out if I could potentially do that, to give 110% at work, but give it 110% and being a mother. And obviously being young at the time, I started, I was 23, turning 24 that year. I was a kid, I don't know, but I knew what my intentions were. And that's the best that I could come up with. Like, okay, this has to work. That give me what I'm looking for. Because I definitely wanted to consider having kids, around my 30s.
Right. Thank you so much for that.
Yeah.
Okay, so before we go into other questions, can you walk us through like a day in the life of like a spine specialist, from like when you clock in to clock out, like your surgery days, non-surgery days,
Sure.
patients, just,
Sure. Yeah. Okay, sure. So how, because I also do inpatient care. So because we have this beautiful group of PAs, we share the call. And what call means would be like, I would be responsible. I'd be the first point of contact and responsible for our patients that were admitted in the hospital, more likely due to the fact that they've had spinal surgery with us. And so my call would start at 8 a.m. on Monday and would finish at 8 a.m. the following week. And so, so when I do have call, what it looks like is I'd wake up probably before the sun is up, early in the morning, so I could round in our patients that were inpatient. And so I would see our patients, see how they're doing, set expectations, and communicate with the surgeon how they're doing, what's the expectation, are they getting discharged, are they staying, or they have to meet their mark before they can go. And so I'd round. And then on days when I'm in the operating room, I go from there, I'd round, and then I go and I would operate with my surgeon for the full day typically. And then that would be my day on an OR day. On days where I'm typically, I'm in the OR 2 days out of the week, and I'm in the clinic 3 days out of the week. And on the other days, I'm in clinic. So I round in the morning, and then I come back in the office before our first patient at 8. And I would then, we would start clinic together. And how our clinic is run is that typically, ideally, because we are a concierge type practice, we spend a lot of dedicated time with these patients, which meaning with an out of network model, how can you understand what's going on with you, or for us to understand you between the complexity of what's going on in 15 minutes? It just doesn't work, you barely have time to breathe, none of them like dictate a note, and so on average, once you get the reps in, you can always figure it out, and you get to know the patient, what's going on, but we would on average spend up to an hour with our new patients. We have patients, these patients, they come and they feel like, we're usually their other opinion, because if they're not feeling satisfied with their doctor, or they don't have a good connection with their surgeon, or they feel like they're not getting a good response from their treatment, we are always that extra person, because they're like, this is not working. Let us find someone else that can listen and see if someone can give us a good answer. And so we definitely have a lot of new patients that come from all over the country and all over the world. That fly in to see us, or right by Dulles Airport. So we're really lucky that we have folks that come in to see us. And now, of course, with after things transition and change because of the pandemic, we really opened that door to have new patients make connection who can't physically travel, or they want to see if it's worth the investment or the time, and they'll try to get to know us virtually. And we try to have that consultation virtually. Obviously, it can be very much of a challenge not doing a physical exam, but we can at least give them a snippet or an understanding what's going on with their spine and what their images say, and figure out, what we would recommend if they come and see us, that kind of thing. And so we would see patients. So typically it would be around an average of three PAs assigned to the surgeon. I make the schedule, so I do the assignment, and we rotate evenly, and typically pre-ops and post-ops are typically more dedicated to the surgical PA, because we build the rapport and they want to see us back, and we know them from the beginning to end, and so we prefer to see them. But otherwise, we mix it up, and they're office-based PAs. Obviously not in surgery, but can pinch hit whenever if they would like. And some folks just prefer being office. Not everyone wants to be in the OR. It is more work, it's more work and more time. But we do value office-based PAs, they definitely work really hard. And, so I'll go in and see a patient, work them up, figure out what's going on, and build a rapport and figure out what the plan is, go and tell the surgeon, and I have a good relationship with our surgeons, and they're like, they trust me. They trust me, they know the plan, we review the images together, and they're like, I got it. And they'll go on in. And again, for the second time, we go up to the computer, pull up all the images, review it with the patient again. This is what's going on. And so through that replication, and having the patient analyze, this information, because most of them are non-medical, it's a lot to understand the why if they hurt, and the why to get to the point of what can really help. And so the surgeon helps kind of formalize and confirm that plan and what the mutual agreement would be. And then we move on and we figure out what's the next step until their next visit. And so that's what happens in the clinic typically. And that's how, and of course, there's always administrative stuff, phone calls, patient questions, paperwork, disability, FMLA, authorizations, there's always other stuff. And so we try to give our team a work-life balance, and we ideally would like to have administrative PA, but sometimes, we all pitch in to fill in that role wherever that's needed, because it requires a PA to do that work. And so we do all that as well. So we have an administrative role that we all kind of share to make sure that, it's not just seeing patients. There's a lot of, the other background work that people don't appreciate that obviously that's why we're PAs, the docs don't do, that someone has to do, and that it requires a provider. So, sometimes you got to just do that work too. And it may not feel as rewarding, but it's necessary because it provides efficient care for the patient so they can get their imaging study, get something on the book, or figure out what or expedite their plan. So yeah, so that's kind of what my day is. And then when I'm done with that, I come home and I'm a mom. I have 2 boys. I have a 5-year-old and a 5-year-old and a going to be 5-year-old and a 2-year-old. And literally, I almost forgot about this, but that's why I have alarms. And literally driving my son home from Taekwondo, and it's 6:45, and I'm like, okay, buddy, mommy's got to work. Do not go down. I'm in the basement. We're totally quiet enough. I'm like, dude, and I lock the door. I'm like, don't bother mommy. There's food on the table. Go find daddy. Mommy needs to work. and then that's how usually my evenings go. But I enjoy it all. It's fun.
Thank you so much for dedicating the time to do this. Thank you. So, what does your role look like as the lead PA? Like, how did you become the lead? I mean, of course, it's because you're awesome and amazing at your job, but how have you been able to adapt to that role, and has it led to other leadership roles within healthcare?
Oh yeah, that's something cool to talk about. I can share with. Again, I think what it comes down to, not only and you understand, and people get to being a PA because of the medicine, but not only the think about behind the medicine is not just the academic part of understanding what's going on. Of course, that's really key and important, but it's the human interaction. You have to be their confidant, their therapist, their listener, and their leader, whoever it is that you need to be to that person. I think, as you understand, medicine has changed. They're the consumer. They choose to come to you. They can go other places. They want to come to you they have to be driven. And so we have to give that to them and build that relationship and that connection. And so, I think through that, just evolution and understanding that, I evolved myself as a person. And then trying to understand, human interaction, not only, in that role between patient and provider, but then also with each other as coworkers, right? We're not made to be equal and the same in that way. Everyone has different feelings and emotion about things. We all have different opinions. And it's about finding that balance of being able to communicate well, respecting each other, and finding a way to show mutual respect. And I think I have a great team that I work with, and it's about finding to understand and also give how to give feedback, how to give constructive criticism, how to talk to people and say hey, this is what we can do better. It'll better ourselves, it'll better our craft, and it'll be better for our patients. And honestly, that part is just time in life, to figure that piece out. And then because I kind of figure that out maybe, and then, but that's the person that I am, and I enjoyed it. I think part of it, I'm a firstborn person. I'm the firstborn out of my sister and I. I've always been a little bit that controlling, having to always do everything right, a little bit of that. And that's in my nature. But of course, between marriage and life and kids, I can't burn out. I want to be happy. So it's definitely figuring all that out on this journey and getting to where I am. It just comes down to being able to be well liked and enough but understand that and be respect. It's respect. It's not it's about respect is really what it is, to find mutual respect in the people that you work with and try to figure out how to communicate even when it can be conflict or challenges, how to communicate with others. And that's what it comes down to. But again, in luck, I work with, great people, and we always try to communicate well. And that's what you're also trying to find in a work environment. It's not necessarily the field. It's going to make or break to make you happy. It's the work environment that you're in, because you're in there all day long. Right. And so that's what matters.
True. Thank you. Thank you for that. So we have a few more questions before we move on to the case study. So one student wanted to know, when you are unable to locate the exact pain level of a patient's spine, would you recommend a nerve conduction study? What does a nerve conduction study tell you?
Okay, great. Yeah. So as far as, people call sciatica radiculopathy, it can definitely present as different kinds of symptoms. People think about a shooting type of electrical pain or just pain. But again, it's the worst that people describe. And when you hear it enough, you can understand that maybe there is a radicular component from dysesthesias, the paresthesias, and the pain pattern, whether it maps a certain distribution, or it may feel in patches. And that can be very appropriate. They just feel it in their shoulder, which we'll get to actually a case study. They'll feel it just in their shoulder, or they'll feel it like just in their glute or their butt, or a little bit like in their hamstring. And that's how nerve symptoms can present. And so with that in mind, it's kind of understanding, okay, do you think it's radicular? Do you think it's spinal? Do you think it could be peripheral? That's part of it, part of your differential. And then from there, trying to understand the pathology. A lot of people knee jerk into an EMG because depending on what specialty, because it is a service that one can provide. So unfortunately, people who just go EMG heavy without understanding pathology, it gets lost a little bit. There are folks out there, never had an MRI. Oh, but you have arm symptoms? I'm just going to EMG one arm, or not even all the muscle groups. And so also that's another thing. Not all EMGs are really objective. And so a part of that is like, there has to be the EMG part. There has to be, so there's a motor part, there's a sensory part. It's like, did they put needles in you to check the muscles? Or did they just put little patches on you and just look at the current? Did they do all the muscle groups, or did they do partial, right? Because if you understand, how many nerves are you testing? And so if they don't really test all the different nerves, like, how do you know? They may base it off of one symptom. And so it can be, for us, that's inappropriate, because, we always want to do bilateral to compare, both of extremities. And we also, we always make sure that it's test multiple muscle groups. And we also want folks to go to places or facilities that have a good reputation in doing, credible EMGs. And when they print it out, there's graphs, there's understanding, they tell you different muscle groups and whatever. And the detail is very clear that this is someone that probably does a better job than when you get, sometimes it's like, they don't even tell you necessarily what nerve, specific nerve. They'll say something like, C6-7 nerve. Well, what does that mean? Does that mean both nerves? Does that mean, which exiting nerve, which muscle are they correlating? And so that's kind of like, that's important to kind of understand where you believe the pathology is coming from. Then is it dedicated imaging studies to make that make sense? If I think someone that has, an acute radiculopathy, I'm not going to get an EMG, because an EMG, the information that may not even show up. Sometimes it has to be 3 to 6 weeks after symptom onset, unless they're completely weak, so it may not show up. So that's not going to be the make or break for me. I'm going to get the imaging study because I think they have a disc herniation, and I'm going to confirm my diagnosis that way. Really glad I locked my door, because I already hear the little handle trying to get it. Oh my goodness. But yeah, so that's where what we are really we're really critical about like who does the EMG and how the EMG is done. So our guys that do the EMG, it has to meet certain marks, and so it really is. Don't ever give me the graph. I will never understand all the information on there. So it's really helpful when patients do have an outside EMG. I give them the graph and the translation. I'm like, is this a good one or not? Like, can you explain this to me? Is this credible? Is it reliable? Because sometimes, again, for my standpoint, it's like, okay, I see maybe many levels of stenosis, and I'm trying to figure out with someone with significant symptoms and a mix of symptoms, do we need to surgically address all these levels, or do we need to surgically address a certain amount of levels? Because not every level that looks bad needs surgery. We're just trying to treat the symptoms that are presenting, right? So that's where that matters, if that answers the question.
Thank you. Thank you. So the last question before we go into the case study is, does the treatment for a compressed nerve in the spine always include surgery?
Great question. So, I mean, the depth of that comes down to how long has the patient have symptoms, how debilitating the symptoms are, and then your physical exam. Is there a neurologic deficit? Is there a lot of paresthesias or sensory changes? Are there other findings there that could be neurologically concerning? And so all those things play into a factor. And also then correlating the imaging study. How much stenosis is there? How pinched is it? And does that disc herniation or that stenosis, is it calcified hard material, or is it soft, fluffy new disc herniation? And there's a chance it can slowly resorb and shrink, and the nerve can heal over time, and there is no neurologic deficit, that kind of thing. So it is, we play all that into mind when we make a decision or help the patient understand exactly what makes sense for the patient. You know, the logarithm is like, oh, you have nerve symptoms, I'm going to inject you a bunch of times without an MRI even. There are patients out there and they'll come to us and like, well, let's figure out where your pathology is. Let's see if they're injecting the right level. And L5 radiculopathy does not mean that we inject the L5 nerve and their symptoms go away, right? So we really have to understand that before we start exposing patients to steroid. So that kind of stuff. No, but our goal is most patients, and the statistic is like 8 out of 10 patients do not need surgery when they have a disc herniation radiculopathy. They can get better. Of course, we're a specialty practice. Our volume, we're going to see more folks that have had chronic symptoms and require surgery. But when you have someone with a big disc herniation and they have a new acute foot drop, and we just talk to them like there definitely is going to be a time that's important to intervene surgically to make sure that they have better recovery and resolution of their weakness, right? So that matters.
Thank you. Thank you so much, You've had some amazing responses and just a great interview overall. Thank you. So we're going to jump right into the case study, guys. We're going to allow Thao to take the floor and share her screen or walk us through a case study, whatever you want. So we're excited for this. And if we have more time at the end, guys, we'll answer more questions. I still see some questions coming in from students, but if we have time, we will.
Okay, sure. Here. Okay, so here we go. We have a 60-year-old female that presents with intermittent pain. So in her upper trap and her left shoulder, and tingling and numbness down her arm in a diffuse distribution, kind of all over. You can't, she can't tell if it's more her fingers or her thumb, so you can't differentiate. She feels it in her pinky. So we can't tell if it's 6, 7, or 8, but something that's diffusely down her arm. It's been ongoing for 6 weeks. She's not sleeping well. She doesn't. Oh, it's her left arm. So it's not her dominant arm because she's right-handed, but it is her left arm. So because she doesn't use it for everything, she does feel weak in the grip, but it's not necessarily impacting her in that way as far as her function. But she had some neck stiffness from the beginning 6 weeks ago, maybe some pain and stiffness. But it is getting a little bit better, but she's just like, it just feels kind of numb, and my shoulder hurts a lot, especially certain times of day, or by the end of the day, I'm tired. It can be from a 7 out of 10 when it hurts, and it can be like a 1 or 2 out of 10 when it doesn't. Aggravating factors, nothing that she does aggravates her necessarily, or actually we'll say that, with repetitive motion or trying to lift or move or using that arm, it does bother her more, it throbs. Alleviating factors when she lays down or puts her arm over her shoulder or over her head, makes her feel better, right? And so this is a primary care setting. She presents to the primary care. She's like, it's just not going away. What do I do, right? With the physical exam, right, you start with palpation. On the cervical spine, nothing really hurts. Nothing really hurts as far as palpation in the upper extremities. With motor exam, passive range of motion, nothing really hurts, right? She's having shoulder pain, so you're going to look into like impingement signs of the shoulder and go do all that. And never remember any of all the names, but I have my 3 they always say and document, but there's no shoulder impingement signs. So that's good. People with like truly degenerate, and again, people with a bad neck or radiculopathy can have a bad shoulder, right? In a shoulder tear. But the difference is like someone with significant, DJD in the shoulder, significant shoulder pain, they'll tell you it's severe pain. It's hard to sleep on it. It's just incredible. And it's just in the shoulder. And of course, you should see some impingement signs with that. But definitely for folks with potentially a cervical radiculopathy, they can say their shoulder really hurts. And so it's really important to do that physical exam and that range of motion in the shoulder to understand that. More on the exam as far as with resistance, she has her grip strength is 4+ out of 5 in the left hand, but otherwise the rest of the muscle groups are 5 out of 5. Important test that we always do is her Sperling's test, right, to see if we close down the foramina, does that reproduce some of her arm symptoms? And the answer is it does not. And then because she's having some paresthesias in her hand and down distally to down her extremity, right? We're going to look at, is there Tunnel's, is there cubital tunnel syndrome, is there Tunnel, or looking for carpal tunnel, that kind of thing. All of that is negative. She does have. We're also got to look at long tract signs. She does have a positive Hoffman's, which can be indicative of something of a long tract sign coming from the cervical spine. And deep tendon reflexes are 3 out of 5 in the upper and lower extremities. No clonus or Babinski's. And so you can find folks with long tract signs. What does that mean? Or hyperreflexia. What does that mean? It can, the range is a statistic, I believe, is like you can find it and it can be normal in females ranging between in the 30s and 50s. But otherwise, but that's something clinically important when you see hyperreflexia or Spriss reflexes. And so in your differential diagnosis, what do you got to think? Okay, well, cervical disc herniation, right? Cervical stenosis, but also cervical myelopathy. Cervical myelopathy is always something that, I enjoy talking about and coaching is because myelopathy is a sickness of the spinal cord from spinal stenosis. And people with myelopathy, it's not pain. Pain is not the symptoms. But the questions to ask is, well, do you have dexterity issues? Do you have issues buttoning buttons or fine motor movements, handwriting changes? They're definitely like vague and weird, dropping things all the time, fumbling, unsteadiness in your feet, overall heaviness in the arms and legs. Worst case scenario of advanced, bowel bladder incontinence, that kind of thing. But folks who come in with incontinence, they're just like, my hands just are numb and I'm dropping things, but not necessarily pain. And it's through our physical exam that we kind of uncover this usually. And so that's important to ask. But we'll start off with imaging studies, right? X-rays. X-ray is going to be the first thing. If we see a lot of diffuse degenerative changes in the cervical spine, it can be indicative, and we see really narrowing of the facet joints. More likely is there a congenitally narrowed canal. Do you hear that, my children? They're knocking. Does that bother you? You don't hear it? No. Okay, good. Good. But otherwise, those are things that are going to give us an understanding or that they may have spinal stenosis. And of course, being that the spinal cord is very vulnerable in the neck in having impingement of the cord, then that gives us indication that we would obtain a cervical MRI to understand where that's coming from. So we see a lot of that, folks with, in this case, an acute, semi-acute, presentation of radiculopathy. And but an underlying more bigger problem is that they actually have potentially cervical myelopathy from bad spinal cord stenosis, and then we have to understand what that is. What does that mean for the patient? Is myelopathy something that always has to be surgically addressed? Not necessarily. Depends on what the pathology is and what their symptoms are, but something that does need a spinal specialist to watch and manage. Because, what we're trying to avoid is, the spinal cord getting sicker and leading to issues like paralysis. right? Long-term symptoms. Eventually, if unmissed or diagnosed, you see these patients in a wheelchair and they're like, oh, I just don't know. I just can't walk anymore. If they don't have good support or understanding, these patients are not diagnosed, and then it's a hard and challenging thing to deal with, from a surgical standpoint. But going back to treatment, you see this patient, what do? You got to assess the symptoms. How much are your symptoms bothering you? Does it bother you a certain time of day? And what are medications you can consider? So, it may not be as bothersome because it's getting better, but it's still there and persistent. So, anti-inflammatories are definitely, looking at their medical history, that's reasonable. Obviously, a favor or a common choice that providers use is like a steroid pack, a taper, to help decrease inflammation quicker, and it can make them feel better. Sometimes with numbness, it can be harder for the patient to understand, is my numbness getting better on a medicine? Like, do I feel better? But it's easier with pain. When patients have a significant amount of pain, they'll feel that their pain is better after they're taking a steroid pack, muscle relaxants, neurolytics like gabapentin or Lyrica, helping to take their, figuring out or helping them with their pain in the interim. That's ideal. And then getting them either to physical therapy or more likely a spine specialist to be evaluated if you think they have a disc herniation. So that way we can expedite the process, get them a cervical MRI, unless you have the support or the ability in your practice to document well and to get authorization to get the MRI, because that's the other hurdle. You can't just give them the MRI and they get it. You got to document right and understand what the insurance is expecting for the patient to fail first before they'll approve to get that MRI. And for us, we know the game, so it's more likely, it's better for us to get it sometimes, than the patient. Usually they'll come in, they're like, oh yeah, my primary care gave me the order, but it got denied by insurance, so I still don't have it yet, kind of thing, which is common when they haven't seen a specialist yet. So that's the case.
Thank you so much for that case. Thank you. That was a great case presentation. So we're just going to wait for any questions about the case that the students may have to roll in, but I did miss the question. A student wanted to know if you've ever worked or shadowed with a PM and an RPA, or if you haven't, was it ever something that you considered?
Have I ever shadowed one?
Yes, PM and R.
We have a couple PNMR stuff. Like, we have physiatrists, and so on our non-operative arm, we do have PAs that work on the non-op side as well. But are they shadowing me, or I'm shadowing them, or have it worked for?
So did you ever shadow them before you became a PA, or have any?
No. I did for a little bit, like maybe for the summer, in order to kind of understand the process of our non-operative team, and to see, to see how we can improve the PA role. I did go over there and be a PA on their side for the summer, and doing a little bit and jumping back and forth. And I had fun doing it. I mean, it's just a different population, and it's, and again, like, there are new things that I, or that I learned along the way, and working with our non-op side is fun. Because they definitely teach me things that I forget about, or that I don't see in my world day in, day out. So no, but again, a part of a spine specialist like type of model is that you learn the non-operative side, and you need to be able to treat that, not just know how to offer surgery, right? That's the key thing. If you don't give patients the whole spectrum of things, then they feel like, and they don't feel satisfied or informed enough. They're going to go find that other avenue. And even if they want to talk about something that may not necessarily are a candidate for, it's important to kind of throw it out there. I mean, because we put in artificial disc in the cervical and lumbar spine, but not necessarily everyone is a candidate for cervical and artificial disc, right? You have to have the right kind of pathology in order to support a kind of implant. And so it's really important for them to know why or why not they're a candidate for it. But, you know, they want to hear it because it sounds so cool. Like, why can't I have it? Why are you not offering it to me? A lot of folks can get it, but there are a subset that is just they have too much degeneration or arthritis or in their facets or something else neurologically that surgery doesn't make sense for them, because that's not going to meet their expectations if they still have, you know, these symptoms.
Thank you. And last question is, how long did it take for you to get comfortable and feel confident to go about your day through all of this?
Oh my gosh, years, right? I mean, years to build up confidence and understanding and you know, tackling each obstacle as you come along, and how do you get out on the other side, and losing sleep at night, you know, worrying about patients, making the right decision, right? Medicine is not, it's not about making the right decision. You do the best that you can, and hopefully it's just a decision that's right at the time, and things happen, you know, everything comes with risk, and how do we protect the patient, minimize risk? And so, you know, constantly juggling all these things, it takes years. I mean, you don't just learn the information and then spit it back out. I'm still learning. I'm still learning to this day. You know, we also have, there's also an education side to our practice where it's kind of like grand rounds, where we dedicate an hour. So employees are paid to be there, and on our clinical side, and they're not seeing patients. We meet together, our medical assistants and our providers come together for an hour on Friday mornings before clinic starts at 9, and between 8 to 9, we're reviewing cases, bringing in outside providers for education, rehashing some of this, just everything that we do, because we have new PAs I've never heard it before, and it's always improving, you know, what we do. And because I may say it one way and another PA may say it a different way, but maybe the way they're saying it, I like it better. Maybe I'll change how I'm saying it. So it's really important to hear what everyone else is doing so we can improve each other. And so that's important.
Thank you so much. And the last question is, how involved are you in surgery as a PA? Is it like just a first assist role, or you were saying are there residents there at your practice?
We are not a teaching hospital type of facility. We're a private hospital, so currently we don't have that structure. And so I do anything, and through my scope of practice, I do anything that in tandem with the surgeon. So we do anterior lumbar surgeries. I help with the exposure. We're in there together. We're a team. Repairing vessels, repairing peritoneum if we need to, putting in cages, putting in screws. We do robotic or stealth technology to put in screws or whatever open back in the day, a decade ago. Now there's all these neat instruments out there, old school style, open up, put in a screw, look at your x-ray, put in the screw. I mean, these are things that the surgeon does that I assist with, but it's part of our scope of practice that we work together. But obviously, I always tell the patient, they need to hear that understanding that your surgeon is doing the surgery, but I am doing what I need to assist him in the surgery so that it's as safe as possible and for him to be as efficient as possible. And so, I mean, it's 4 hands instead of 2. And so it's not like it's not like a thing where, in a teaching hospital where a resident may do the surgery and someone, the attending standing there. But no, the patient is looking for safety and the experience. And of course, the surgeon's doing the surgery, but I do my part, whatever they need.
Thank you so much. Thank you. So guys, we are up. It's 8 o'clock, but we'd like to thank Thao for everything. This has been a very great session, very informative. Thank you so much for sharing your journey and for presenting the case study.
Thank you.
And taking the time to answer the questions for the students. Thank you so much. You're getting lots of
my pleasure.
Thank you.
Thank you so much.
Thank you. Thank you.
Yeah, if there's anything I can do to help or whatever, you can reach out, and if there's any way I can help, happy to help and help you with your journey, because it's important. It's important to figure out what gives you passion, what gives you joy, and also pays the bills. So
Thank you so much, Thao.
you're welcome. Thank you.
You
Take
have
care.
a wonderful night. Thank you.
Thank you. Good night. Bye bye.
Bye.